Good evening and welcome to Rural Medicine Grand Rounds. I'm Dr. Stuart Glastonbury. Tonight's case is on transient ischemic attack presentations in rural general practice. Discussing our case tonight, we have Dr. Jason Denman, Staff Specialist, General Medicine at Toowoomba Base Hospital. Please welcome Jason. Next to me, I have Dr. Blair Koppen, Medical Superintendent, Warwick Hospital. Please welcome Blair. And on my far right, I have Tim Richardson, Clinical Nurse in Stroke and Rehabilitation, Toowoomba Hospital. Please welcome our specialist and expert panellists. As usual, we're being live streamed around Australia. We have a number of participants watching remotely, so I encourage you to join the discussion by emailing your question to media@qrme.org.au, or you can use the hashtag on your screen. Our presenter tonight is Dr. Robert Heffernan from St Andrew's Medical Clinic, and his presentation will be on transient ischemic attack presentations in general practice. Please put your hands together for Robert.
Good to go?
Yeah.
All right. So I'll start with the dreaded phone call, because probably like the rest of you, that's probably one of the worst parts of general practice, is the constant interruptions with phone calls. There was a national work-life survey in 2012 which listed it as one of the top 10 stresses, along with working long hours and dealing with increasing patient demands. And I think this sort of sums all of that up. And you've got Mrs H, and she's just called and she's worried about her dad. You've never seen him before. He has an appointment with one of the doctors tomorrow, but is wondering if you can fit him in tonight. It's the after hours are already booked full. Can you fit him in? Now, Mr DT is a 67-year-old man. He presented following a funny turn last night. He's a thin, tan gentleman. He's brought in by his daughter and his wife. His wife has obvious mobility problems, which she reports is because of multiple sclerosis. Before he gets here, though, you manage, being a GP, we look through the chart and see what we can find out. And the first thing that strikes you is a warning, needs MMSE, which doesn't sound very promising. He's got a past medical history of arthritis, diagnosed in 2002. He's got some industrial deafness, lactose intolerance, colonic polyps, diagnosed in 2003, a bit of reflux, some COPD, a narrow C5-6 disc space, and with a normal carotid Doppler in 2011. Going through his medications, he takes some aspirin, some esomeprazole, some meloxicam, some tiotropium, but that hasn't been prescribed for 15 months. Regular B12 injections, and he's got no allergies. You notice that he's an ex-smoker. His alcohol status isn't recorded, his marital status is not recorded, and his social history is not recorded. He last had some bloods done about 15 months ago, and they weren't very exciting. It was cholesterol, some prostate, thyroid tests. And he presents with this funny turn. Essentially, he's presenting with three, and I've written syncopal here a bit erroneously, 3 episodes of near syncope overnight with altered level of consciousness. They've now completely resolved. His wife reports that he was conscious but with slurred speech. She found him on the floor. He recovered within minutes but had a recurrence on 2 occasions over the next 20 minutes. She was going to call the ambulance, but the patient refused. He was quite combative about this. He has a poor recollection of events. Although taking the history from the wife and the daughter, there was no seizure-like activity. He had no infective symptoms. He denied any cardiovascular symptoms, and he also denied any neurological symptoms. On examination, he's afebrile. His blood pressure is 130 on 60. There's no real significant postural drop. His pulse is 84 beats and regular. Heart sounds are dual. He's got no carotid bruits that could be appreciated. His chest was clear. In terms of neurological examination, his cranial nerves were all completely normal. His speech at this stage was normal with no dysarthria. His upper and lower limb neuro examination was completely unremarkable. His coordination was normal. He's got a painful left middle finger and a painful nose. In the GP room, of course, we can do a couple of tests, and we did a urinalysis which just showed some protein and some leukocytes and the following ECG. I'll leave that there for a couple of seconds for people to take in. And as part of his follow-up after that ECG, which was fairly unremarkable, an ABCD2 score was done, and this patient scored 1 point for his age being greater than 60, no points for his blood pressure. he scored 1 point for speech impairment without unilateral weakness. His duration scored him no points, and he didn't have diabetes, so getting a score of 2. And I'll skip that one. I might come back to that slide a little bit later. In terms of management, at that stage he was otherwise well, so he was started, his aspirin was changed to astaxanthin, his blood pressure was normal, and he was sent for more bloods to check out his lipids. And there's some more of the other options there. He's an ex-smoker, so no need to deal with that. His alcohol intake wasn't looked into at the time, and the other things were left for more preventative care in the future. In terms of investigations that were ordered, a full blood count, LFTs, fasting lipids and glucose, a CT scan, obviously in general practice, difficult to get an MRI, and some carotid imaging of his Dopplers. The results were very unexciting. His cholesterol level was 5, his HDL was 1.2, his cardiovascular risk assessment came out at about 10% or a moderate risk. His Doppler showed no plaque, and echocardiogram didn't show any cause for any thrombus on a transthoracic scan and was otherwise normal. And in his case, there was no surgical intervention, but we might come back to that a little bit later too. He comes back for his results, and interesting, on to the next case, they talk. His wife says that she thinks he has Alzheimer's disease, and a mini-mental state was done, and he scored 23, but we'll get onto that a little bit later on tonight. So I was going to ask Jason a question first, if that's okay. Has he had a TIA?
Good question, Robert. So really the history as we're presented is really not suggestive of a TIA. Atypical presentations certainly happen, but in general, what is a TIA? I guess is the first question. So really, what we're looking for is transient neurological symptoms that can be affecting either the eye, the brain, or the spinal cord that can be referred to a vascular, a single vascular territory. Okay. Non-specific presentations like altered level of consciousness without lateralising signs, syncope or near syncope, which is what this man had, transient loss of memory. Those sorts of presentations are atypical and, usually are something other than TIA. Having said that, if you do an MRI on all these people, about 10% of the people who present atypically, will have evidence of ischemia on their MRI. So it's not an absolute rule, but the history that you provided on this man suggests a cause other than a TIA.
Fantastic.
So I was just wondering, Blair, this seems to be a fairly common presentation in general practice, and especially in rural general practice, and this may be something that happened a week or two ago. If they're having any difficulty getting in to see a doctor, or the availability of the doctor is not great. So in this sort of a case, what would be your first kind of, in a rural setting, what would be your first kind of line of, I guess, follow-up or interventional follow-up, or
Well, I think history is the most important thing, and collateral history of the presenting event would be the most important thing. So you have to go through the past medical history, all the risk factors, medications, all of that, and then just a thorough examination to see if there's any residual factors still there, cardiovascular and neurological, and then the tests. I do most of those tests that were done, ward test urine, sugars, cholesterols, ELFTs, full blood counts, thyroid function tests, and then depending on what the presentation was, maybe echoes, maybe Dopplers, EEGs and echoes, whatever.
How accessible are those things to you in work?
EEGs we have to refer to Toowoomba. CT, we've got a low resolution CT. MRIs in Toowoomba. Doppler we can do. All the bloods we can do.
So on physical examination there wasn't much.
No, nothing.
On the investigations that were done, there wasn't much. Jason, I assume that this is a fairly typical finding in people with TIAs. I mean, as the nature of TIA is, it's transient. So for registrars that are faced in this sort of position where there is a real uncertainty, and you might, and especially in this case where it was very atypical, what other kind of things might mimic a TIA?
Yep. So certainly there's a long list of things. If you look at the data, there's just a few things that account for the majority of presentations, and those are, seizures, and as many of you would be aware, post-seizure, a seizure may be unwitnessed at home, and you can have a Todd's paresis phenomena post-seizure, so, mimicking hemiparesis. People recovering can be confused and have slurred speech in their post-ictal phase. Migraine, particularly hemiplegic migraine, is much more common than you think. So certainly any history of headache, either preceding the onset of symptoms or developing after the onset of symptoms is significant. Psychogenic hyperventilation, so usually associated with anxiety or stress, can certainly cause is a not uncommon mimic, I think, and delirium as well, particularly in the hospital setting. We not infrequently get called, acutely to come and see patients who might be thought to be candidate for stroke lysis, who are thought to having a stroke, and it turns out that they're actually delirious. Those would be the most frequent mimics, I think. There's a long list of other things as well that with less frequency.
So Jason, on that, in general practice, the dogma that's drilled into us is Murtagh's diagnostic strategy, which you're probably familiar with, I'm sure, which talks about serious things not to be missed, and I guess taking things as not missing the really important thing that's being managed now. If a patient presents with symptoms that you think is a TIA, do you treat it as a TIA, or are you happy to say, oh, look, that's probably just a migraine?
Look, I think it depends on the context. Obviously, if the patient's presenting to you and they're still symptomatic, you don't know that that's a TIA, that might be a stroke in evolution, and they should go straight to hospital, particularly if they're, potentially a thrombolysis candidate. In Toowoomba now, as in, many other metropolitan centres, thrombolysis is increasingly becoming available, and there's a 24-hour a day, 7-day a week thrombolysis service at Toowoomba Hospital now. So any patient with onset of acute neurological symptoms that might be a stroke, within 4.5 hours needs to call an ambulance and get to hospital as quickly as possible so they can be assessed. If the patient's sort of presenting to you and the symptoms have already resolved, then obviously that's not going to, or not much less likely to be a stroke. If you do diffusion-weighted MRI is a very sensitive modality looking at brain infarction, and if you take everyone who's had a TIA and do diffusion-weighted MRI, depending on the duration of their neurological symptoms, a significant number of the people who, by the old definition, the arbitrary definition of neurological symptoms lasting less than 24 hours and resolving, a significant number of those will in fact have had infarction and with very small lesions. Depending on the duration of symptoms, that can be up to 70%. If they've had symptoms for as long as 12 hours before they've resolved, 60 or 70% of those people will have a small degree of infarction on their MRI. So, certainly if the patient's presenting post-event, they've had hopefully a lucky escape, and there's an opportunity there to assess them and intervene to prevent hopefully a more significant event in the near future.
So just taking up on that point then, I guess, Blair, maybe if they've had something that resembles the symptoms of a TIA last week, maybe you could say they've had a bit of trial of time and they've survived, I guess. What are the kind of the risk factors, and what could you focus on then in general practice as far as I guess, Rob, you touched on the ABCD2, so maybe we can bring that up as well and talk a little bit around that, but just sort of looking at risk factor management then if you're not thinking about referring off to a stroke unit.
Well, there's certain risk factors that you can't change, like age and family history, but the risk factors that you can would be look for AF, look at the blood pressure and get target numbers there. Are they a smoker? And try and get them to stop smoking. Are they diabetic? Get target HbA1c and blood sugar. Get them to exercise, control their weight, and I'd sort of look at those sort of things mostly in general practice. I'd sort of see whether they're low risk, medium risk or high risk and go through that with the patient as well.
So then if we look at that kind of, I guess, that stratification into low, moderate or high risk, and Rob, you sort of touched on that. Do you want to talk around that a little bit?
I guess just a couple of points on that. The first one I was going to get Jason to comment on was, in my reading around this, my understanding is that the ABCD2 score is much better in the hands of a neurologist or a specialist. It's not as justified in the outpatient or general practice setting. Is that a fair comment?
Look, I'm not aware of any data that shows that, and if you've read that, then I'm sure that's the case. I think regardless of who's administering it, if you're a competent practitioner and you can take a reasonable history, then it's going to be useful. And I think it's not a perfect tool. In fact, it really underpredicts risk for stroke in the near future for people with high-grade carotid disease and atrial fibrillation, but it's good because I think it's a useful tool because it allows you to come up with a prognostic, prognostication for that patient's risk of stroke in the next 7 days, and then act accordingly.
Is it more powerful in a lower ABCD2 score? I guess what I also read was the positive predictive value of a negative score of then not having a stroke is much more powerful than a moderate sort of score to know what to do with the patient.
Yeah, look, again, I'm not 100% sure about that, Rob. So, that may be the case, but I think the importance of it makes people think about, how much risk is this patient at? How should I act? The recommendation is if you've got a score of 4 or more, that you're at high risk, and you should act, urgently in that setting. If you've got a score less than that, then you're at lower risk, and you've got a little bit more time, I guess, to get the patient through the necessary investigations and interventions. But again, fortunately here in Toowoomba, I guess we've got access now to really a 5-day-a-week hot clinic type service for these patients. So any of you who are out there in general practice, if you have a patient who presents to you, who has had a TIA that day or within the last little while, you should pick up the phone and talk to Tim Richardson. Would be a good person to contact in the first instance, or Nasal Genge or myself, and talk to us directly. And usually we can organise to see that patient very promptly. If they're high risk, we try and see them within 24 hours.
I guess one thing with like the ABC tool and those sorts of things is that often in rural areas, people are very hesitant to jump in an ambulance or to get their relative to take them possibly 100, 200, 300 kilometres away to the nearest hospital, and having something like that then it's more of a convincing argument then, I guess, to show them some kind of validated tool or a number to say, hey, look, we know that you're at this risk of having a stroke in the next little while. I really do think that it's a good idea. So I mean, in this case then, let's go over to Tim then. So if this case was a clear-cut stroke and they were in high risk, and then, they came over to you at Toowoomba Base. I mean, I think that probably a lot of registrars out there don't actually know what goes on in a stroke clinic and kind of your workup and what you do. So could you give us a little bit of a background on that?
Yeah, so just with reference to the ABCD2, we have additional sort of risk factors with that, which includes, recurrent episodes within the last week, makes you just automatically a super high risk, as well as also your anticoagulated or not anticoagulated patient in AF or paroxysmal AF. So just looking at the TIAs and, the reference to our outpatient clinic, the call comes through. If we have a clear-cut referral system, which we do have in place, which isn't obviously broadly known, it does have the ABCD2 attached to that. So one of the problems we have is when we get these referrals, these are the symptoms, but there's no ABCD2 done, there's no collateral information. So I guess to make it an easier way to triage how quick we get these patients in, it would be to have the ABCD2 tool with the referral. And that process is they come through to us if they haven't had completion of the tests such as carotids and your bloods and your CT. We would try and get that done early in the morning, and then all those things would be available in the afternoon for the clinic review in the outpatient setting. Yeah.
Okay.
Inpatients, we just, especially the ones from rural, we probably keep them if they've been, made the trip in. We probably can keep them in the hospital until all those examinations are completed prior to discharge.
Do you like as much of that done before you get them, or do you want to get them and do a lot of those things yourself?
Look, if you have access to them, that's fine. But if the referral is, this patient's presented with this, we haven't completed any of the imaging, then we can sort of organise that, hopefully for the same day. We have agreements with the medical imaging department, a slot each day for carotids and CT as required.
I think that's an important point because some of these things, these interventions are time critical. So, really to get any benefit from a carotid endarterectomy, well, no, that's probably the wrong way to say it. The benefit of a carotid endarterectomy is lost if you wait more than 2 weeks. It's really important to get the carotid imaging done, so be that a duplex or you can do a CT angiogram if you've got easier access to that. But you really need to do that ideally within 48 hours maximum, so that you've then got time to act on it and get the patient down to a vascular surgeon.
And do you find the surgeons have tied in with that service?
I haven't referred anyone urgently lately, but my experience in the past has been that if you ring them up and talk to them and tell someone who's had a TIA and they've got a high-grade symptomatic stenosis, that they do their very best to get them seen in an appropriate time frame.
Excellent.
So my understanding too, Jason, is that there's different kind of territories, I guess, for TIA, or if we're going to talk stroke, then for stroke. And we look at the carotids or do ultrasounds and those sorts of things. But is there a kind of a number that you can put on ones that maybe come from carotid or posterior circulation? Like the different sort of circulation beds, I guess, cerebrally for cerebral perfusion and stuff like that. Is there, and especially then, I guess, in the clinical workup too. Like, is it quite a reliable thing to sort of from a physical examination or from a history and physical examination to get a bit of an idea of whether it's carotid or it's
look, from the history and physical examination, often not. I mean, obviously, if the patient describes a history of intermittent palpitations that are sort of fast and irregular, then you're going to be thinking atrial fibrillation as a cause. If you hear a carotid bruit or feel a low volume carotid pulse, you might suspect carotid disease. But I've seen people with high grade carotid stenoses who have no bruits. It's certainly not helpful. In terms of figures, I guess I'd refer everyone who's listening to the Oxfordshire Stroke Classification, otherwise known as the Bamford Classification. So if you do a Google search, you'll find plenty of information about that, and it's a useful way to tie the patient's symptoms into a stroke syndrome or a TIA syndrome, and then localise the potential lesion. And we tend to divide things into anterior circulation and posterior circulation events, and their syndromes into total anterior circulation, partial anterior circulation, posterior circulation, and also lacuna syndrome. So it's worth knowing, about those things, and it just makes it easier for you when you're seeing your patient to think, where is the lesion likely to be. Carotid disease tends to go to the anterior circulation. If you've got vertebral artery disease, that tends to go to posterior circulation. atrial fibrillation, strokes, cardiomyopathic strokes tend to be more often cortical, and interestingly, they're usually more severe than strokes arising from other sources. And there's going to be an epidemic of atrial fibrillation in the next 20 years. Let me tell you all, with the increase in diabetes and obesity and all that sort of stuff. So we're going to see a lot more stroke from atrial fibrillation.
Blair or Jason, anyone, I guess, on the panel, someone coming in with something like this, which perhaps has resembled a recent TIA, is there any concerns around starting any, or should we start them on some immediate management? Aspirin, something, or could a small bleed present as a transient ischemic attack?
Look, usually not. So, I think, I guess it's possible but unlikely.
Okay.
Usually if patients have a bleed, I'd expect them to have a persisting deficit. The history, subarachnoid hemorrhages can have a herald bleed. The history there is usually obviously sudden onset worst ever headache, and the symptoms are maximal at onset, and then sort of resolve. So that's a little bit different to how your TIA symptoms would usually evolve. I guess everyone should have some cerebral imaging, and if you're unsure, the key thing is to get the imaging done as quickly as possible. And I think obviously it depends on, it's more difficult if you're more rural, but certainly in a place like Toowoomba, I think if you picked up, the key in these things is always to talk to someone directly. So ring the radiologist, at Queensland X-ray, if you're at St Andrews Medical Centre, or wherever, and say, look, I'm really worried about this patient. Is there any way we can get a CT urgently today? And usually they'll accommodate you. Now, obviously that might be more difficult in Warwick or Inglewood or places that don't have immediate access to imaging, but usually you can get around that. In terms of should you start therapy, I think absolutely. If you think someone's had a TIA, I'd at the very least start them on some aspirin, and 300 milligrams is the dose that I'd use. There is some evidence out there that for the people at the highest risk, so high ABCD2 score, or the crescendo type pattern that Tim was talking about, there's some evidence for dual antiplatelet therapy, so aspirin and clopidogrel for a limited period of time. We don't like using dual antiplatelet therapy for stroke in an ongoing basis on the results, based on some data from the MATCH trial, which came out a number of years ago, that showed that the bleeding complications outweigh the additional stroke prevention that you get from dual antiplatelet therapy. So certainly not dual antiplatelet therapy for stroke, but there's probably a role for short-term dual antiplatelet therapy, for people with very high-risk TIA. I guess the reality is that prescribing would be outside of the PBS prescribing guidelines, because if you're antiplatelet naive and you have an event, you're supposed to have aspirin, and you're only supposed to have access to clopidogrel if you've had an event on aspirin. So you're prescribing outside the PBS guidelines, and it depends how comfortable you are about doing that.
Often in general practice, and especially in rural general practice, you've got that new patient, Blair, who comes in who you've never seen before, who's 75 and had something that resembled a stroke 35 years ago, not a stroke, a TIA 35 years ago, and was put onto maybe a couple of medications or whatever, and they've been on it ever since. How do you go about especially when they sort of go, oh, doc, do I need to stay on this? I've been on this forever. Those sorts of issues. It's a difficult one.
And often they come in as a new patient, got not much time, but I would try and chase up the notes and get the notes and chase up the old investigations if at all possible. And then I'd just reassess all of their risk factors, maybe do the investigations again, just reassess if they're in AF, go through what's their prognosis like, go through that with them, and have a look at their medications, because if it was that long ago, there might be newer and better medications around. And just make sure they're at targets with their sugars and blood pressures. And then I suppose if they're getting older, have a look at what their falls risk is like, because if they're at high falls risk, maybe it's time to stop the anticoagulant.
What do you think, Jason?
Well, yeah, look, I'd agree with all that. I'd certainly advocate looking for evidence. I've had patients come into clinic and say, oh yeah, doc, I had 6 strokes and 3 heart attacks in one day. And they firmly believe that. And you go searching for objective evidence, and, the period of time that they claimed that this all happened, they're in hospital and all their troponins were negative and their CT shows no evidence of cerebral ischemia. So patients do get it wrong, particularly the less health literate patients out there in the community, and from lower socioeconomic backgrounds and things like that. So I certainly advocate sort of chasing down old notes and imaging and things like that. And I spend a lot of time when I see patients in clinic sort of chasing up that sort of stuff. I think on falls risk, I think we tend to overestimate falls risk and the harm that comes from it. I think there's a lot of things you can do to mitigate falls risk. But once you stop someone's anticoagulation and they have a big stroke, that might be it. They're in a nursing home. I think if they're unfortunately the things that make people high risk for stroke with atrial fibrillation, for instance, a lot of those same things make them high risk for bleeding as well. But the data from all the trials, even in elderly people, the BAFTA trial, which was done in elderly patients over the age of 80, still showed that the risk of stroke or the benefits of anticoagulation outweigh the risks, and there's a strong benefit. And in fact, those older patients often have the most gain, the most benefit. So, I think certainly if patients falling, constantly and catastrophically, then I think that's reasonable. But yeah, I'd just be cautious about overestimating falls risk.
Any questions from the audience? Yep. Lucy.
Can I hijack the microphone for a minute? My question actually goes out to Tim with regard to your team's management of patients in a stroke unit. And I think there was a recent survey from the Stroke Foundation about community support for stroke survivors, and that it was a survey of stroke survivors and their families, and there was a general feeling that they weren't getting the kind of support and multidisciplinary care that they wanted. And I just wondered, obviously when they're in hospital and acutely, they're getting a lot of support and a lot of multidisciplinary care, and then of course they're transitioned out into the community. What would be your advice for rural general practice registrars and general practitioners for helping us to support these patients in community and continue that recovery process and rehabilitation?
Yep. Look, we're lucky in Toowoomba we've got an outpatient allied health service that's fairly accessible. There is a little waiting list, and that, usually post-discharge these patients don't find out until it's 2 weeks out that things aren't as rosy as what they were in the hospital before they left. So in the rural, I guess, if we receive those stroke patients, we do try and link them in to the closest allied health available from their location. And that's probably the best we can do. We also advocate within our stroke services, National Stroke Foundation, I think it's Stroke Connect, which basically is, patients can contact them for support. They provide newsletters and support groups. And there's also a lot of local stroke survivor support groups within our district. I think, I'm not too sure out past Toowoomba, to be honest, but I know there's some in Gatton. We've got Toowoomba's local trust group, which I advocate them, as well as local support. Does that help?
Yeah, and if I can segue on perhaps to Blair, your experiences working in a rural area, what kind of sort of, have you had any difficulties or barriers to getting multidisciplinary team care involvement post sort of acute discharge for your sort of chronic follow-up and management and rehabilitation of post-stroke?
I suppose there's bed pressure in referral hospitals like Toowoomba, and Sometimes it's hard to get past that registrar to get a patient into the hospital. That's just everything, not just TIAs in the past. And I think the news that the stroke unit is trying to do very aggressive early treatment is fantastic. We do have a rehab unit where we are. We're very lucky. Allied Health Service, Monday to Friday business hours, but we've got limited beds as well. So often it takes a long time to get patients in, and there's limited number of treatments as an outpatient because they can only stretch so far.
So Tim, I just to come back to you there. So this Grand Rounds is supported by the nursing department here at the university, and obviously you play a very key role in the workup and the management of those sorts of things. So, and we have a lot of nursing staff who are watching this tonight. So I guess it would be interesting for them to kind of understand the pathway from maybe from undergraduate or early nursing through into where you've gotten to as well. If there's any particular way that this can become an area of interest for nursing staff.
Yeah, look, I guess when you complete your studies as a nurse and you go out, and if you're lucky enough to secure a postgraduate rotational position, you get experience in a number of areas. I was fortunate enough to have experience within 5 areas during my first 2 years, and one of them included a neurosurge rotation, which I enjoyed. That's probably what I found the most interesting. And when I came back to Toowoomba, and I've been in Toowoomba for 11 years now, stroke patients I would see in the acute medical area, which is where I have been working, and the closest thing that I'm going to get in Toowoomba to neurosurgical patients, so that's why my interest sort of laid with the stroke patients. And I guess, for the first 10 years of my working in Toowoomba, there has been no focus on stroke care. It's just been an ad hoc and very much reliant on who's on the day. There's been no consistency. So when an opportunity came up to be involved in the improvement of the quality that we provide to the stroke survivors, I sort of put my hand up. If you're looking at further studies, there's some free online training that you can complete. There's NHS, I think it's STARS training, has some advancing modules which are available to everyone, and certificate completion, so it's part of your development points. There's also locally, there's an estroke.com, which is very good, very difficult as well. And if you search a little bit deeper into it, you do find some things just to sort of give you a bit more background and a bit more support in stroke care. And also just familiarising yourself with the National Stroke Foundation guidelines was a good start as well.
Okay, excellent. Jason, you were mentioning that you think there's going to be an epidemic of AF and those sorts of things, and therefore increased risk for TIA and stroke and everything like that. I wondered, I might, if possible, we might throw a question down to Nisal, if that's okay. So there seems to be recently, I guess as the Director of Rehabilitation and Stroke down at Toowoomba Base Hospital, a move towards that model of care, which is kind of that acute stroke unit and that kind of in the tertiary centre and things like that. So I wonder whether you can, talk a little bit around that. There's areas of like cost benefit and all of those sorts of things about managing it, because what I'd like to throw out then too is that whether or I've heard anything about people talking about the GP kind of model of stroke care and having extra training for GPs to actually manage it more in the community, and as there is a push to manage things in the community a little bit more. So yeah, what are your thoughts on that?
Thanks for asking that question. So the stroke unit in Toowoomba, we have now run for about 8 to 10 months. And this is after significant input from few of my colleagues here. Actually, Tim and Jason was involved in setting this service up as well before even I was in Toowoomba. What we do there is we got a 4-bedded unit, and this is embedded within our rehab unit. So any patient who comes to the front door these days would bypass our medical medical unit and get straight away admitted to the stroke unit straight from the ED. And so the patient, the benefit of that is not just because we are having a signboard of having a stroke unit. There's after stroke lysis, the most beneficial intervention in stroke is having a stroke unit, and you only need to treat. If you treat 100 patients, you will have 5 fewer patients will die from a stroke, and 6 more people will be going home as opposed to going into a nursing home. And this kind of benefit you would only get with few interventions. For instance, if you take aspirin for a stroke, you need to treat 100 patients to get one good outcome. So so how do we provide this benefit to the patient is through a multidisciplinary team in the unit. And for instance, there's a medical team who sees the patient on a daily basis, and that medical team will have a seamless transfer of care of this patient throughout the journey from acute care to the rehab because it's under the same unit. Then we emphasize on mobilizing these patients on as soon as possible. It's a myth to say that the patient needs to be in a bed for a couple of days after a stroke because they had a big stroke. So getting these patients mobilized as much as possible, doing the small things right, like doing a dysphagia screen before they have been given the first feed, will reduce the aspiration pneumonia, which is the main killer. Actually, the strokes don't kill patients. It's the complications from stroke that kills the patients. And aspiration pneumonia and the wound care, the skin care are the things that we looked into. Now, how we transform that into the community is the big question. Now, as we take Warwick, Blair's station, there's a good medical team, but the deciding factor in providing acute care at the moment in Darling Downs, as in most of the regional hospitals, is access to imaging. We need to have access to imaging with a CT scanner, and once that access is done, getting the specialist input into that. So we'll probably be looking into, probably in Kingaroy and or Warwick, to have a satellite unit and hub and spoke model where we provide that service through a telehealth. But what is the advantage we have is that now, for instance, Warwick has a very advanced allied health input to that. So the rehab part of that stroke would go there. So how the patients would benefit from that is, again, a seamless transfer from acute to rehab in the same, under the same unit. Whereas they come to Toowoomba for a couple of days, go back there. But there are few things that we need to look into before we go in that pathway. And to be honest, that the moment the message I want to give it to our district is that if a patient has a stroke, make every effort to get them into Toowoomba, and first of all find out whether they can be here within 4 hours, because we can provide that lysis program. For a place like Gandivindi, it's impossible to do, but still those patients, stroke lysis is only one intervention that we do, and there's 90% of chance that's only 10% of the patients would be beneficial from that. Other 90%, including that and the 10%, will benefit from stroke unit care. So all these patients, I would expect for us to get a call and get these patients transferred, at least for the first few days, until such time we all have stroke units in the region. Thank you.
If you don't mind, we have a psychologist in the audience too tonight. Stephen, I just wonder too, like, I understand that especially after people have heart attacks and things like that, that there's a very big incidence of probably undiagnosed depression. And certainly I understand that that's actually an independent risk factor for poorer prognosis. So I guess, I mean, you know, stroke or a TIA, or even that sense of you know, mortality, I guess, then there'd be a role for, and probably not something that we think of much actually for you know, people who are suffering these things, TIA, stroke or whatever, to have that psychological support afterwards.
Yeah, absolutely. In our rehab ward, there's a psychologist based in that ward, so We do have routine sort of visits, and anyone who presents as having depression is obviously gets some treatment from the psychologist as well. When people post-stroke come down to the area that I work in, which is the outpatient rehab, as a multidisciplinary team, we all keep an eye out for depression and other mood disorders. And I prioritise those on risk and begin treatment on those immediately too.
So I guess for registrars especially too, like often, you know, we may see the initial presentation, but then we don't see them until they come back. Yep. I guess having a high index of suspicion that, you know, that it would be normal for people to feel quite upset. I mean, I guess, you know, that's probably normal, but to be at a high level of suspicion, if that sort of is going on, and you're actually starting to meet the criteria for depression,
yep,
to do a mental health care plan and to kind of get the psychologist involved as well.
Yeah, look, anyone post-stroke, I'd be encouraging, I suppose, a little bit of hypervigilance with the stroke sufferer, but also encouraging the carer and the significant others to keep a close eye on the person too, because how that person actually adjusts to that change in their health is something that could be quite transient and on a day-to-day basis. So close monitoring and probably educating the carer on what sort of things to keep an eye out for that could suggest that this person is sliding into depression or even starting to have suicidal ideation.
Yeah, no, it's a really important part, and I think something that probably is overlooked a little bit. So I just wanted to touch. I mean, we haven't had a chance to really talk about the kind of involving the you know, I guess ACAD and looking at all of those sorts of things of whether people can stay in their home or not, which I guess is a very important part of a post-stroke workup and kind of support in the community, and you know, or blue care or nurses or home help and all that sort of stuff. One thing I wanted to touch on really quickly, just to kind of on a medico-legal issue, I guess too, is what's the kind of requirements around driving after a TIA, because that's something that we often, I mean, as GPs, that's the kind of the pointy end question that we always kind of get. Can I drive?
And luckily, there's a really fat book you can read about it, and it's in a PDF. And my understanding is 2 weeks. If you've had a TIA, 2 weeks, you're out. And obviously, if it goes on to develop into a stroke, that would change things again. But anyone that's had a TIA or suspected TIA is banned for driving for 2 weeks, which is an issue in the rural areas as well, I imagine, or more so.
And is that regardless of, is that treatment or no treatment? You know, if they're... Yeah,
that's right, regardless of treatment. Well, as vague as that booklet on who can drive, Fitness to Drive.
Yeah, Fitness to Drive.
It just comments that TIA, you can't have an unconditional licence, you must not drive for 2 weeks. And there's no comment about treatment or management.
Right. Okay, all right, good. Okay. Jim, we've got one quick question. We've got a couple of minutes, so let's...
So can I come back to our original case, whether we called it a TIA or not? What's now reasonable for this gentleman for us to do further investigations? Yep. We've still got to find the cause of his collapse. Yeah. We don't know really whether his impaired cognitive function is worse following this event. I mean, was he 26 before this event? What further investigations should we as GPs now do?
Yeah. So I think Robert's already touched on, you know, the basic things. So, you know, I think it's reasonable to do a full blood count, an ELFTs or a Chem 20 or whatever it's called in your setting. You know, an assessment of the patient's lipid profile, some assessment of their glycemic status, and you know, they would be the important things. You know, everyone needs an ECG and a clinical cardiac examination to go with that, you know, to detect murmurs or other things, and a general, you know, cardiovascular assessment, you know, to look for other evidence of vascular disease, because as you know, atherosclerosis is a system-wide, you know, phenomenon. It doesn't pick off individual vascular beds. Everyone should have some cerebral imaging. In the ideal world, that'd be an MRI, but there's issues of cost and access. So, you know, a non-contrast CT or, you know, even a contrasted CT is very helpful. If the history suggests paroxysmal atrial fibrillation, I think you should make some effort to try and confirm that. And you know, a Holter study is you know, I guess useful for that. Now it depends on the frequency of the patient's palpitations. They say only get it once every 3 months. You know, you might not have a great pickup rate, but be aware that a lot of people who, you know, have symptomatic palpitations also have occult atrial fibrillation where they're not symptomatic as well. And you know, certainly through Toowoomba Hospital you can order up to a 96-hour Holter. So it doesn't have to be a 24-hour study. So you know, a Holter study would be very useful. And as we mentioned, the carotid imaging of some sort. So you know, if you're sending them for a CT head and they've got normal renal function, it's very easy to do a CTA at the same time. But failing that, a carotid duplex ultrasound, and they always assess, you know, vertebral anatomy with that study as well. So, you know, I think those things would be the minimum data set. You know, just to reinforce our points before, so, you know, in terms of that initial treatment, I think, you know, aspirin at the very least. Statin is a good idea, and you know, we could talk about the data around that. But and you know, if people are hypertensive, then a blood pressure lowering drug, be that the first one or some add-on therapy. But those are the, you know, the key early investigations and interventions that I'd sort of be thinking about.
Okay, all right, well, thank you. Unfortunately, we're out of time. Thank you to Robert for his excellent case presentation, and especially thank you to our specialist and expert panel for their extremely valuable contribution to tonight's discussion.